At this year's BGICC International Breast Cancer Conference in Cairo 2021, I presented a talk on BRCA mutations in patients with metastatic triple-negative breast cancer. I started out with outlining that triple-negative breast cancer represents 10 to 15% of all cases of breast cancer, and similar numbers are seen in the Middle East region as well. BRCA mutations are present in about 15 to 20% of patients with triple-negative breast cancer. They could be triple-negative, or actually BRCA mutations can be present in patients with hormone receptor positive as well, especially BRCA2. The new advances in the treatment of advanced breast cancer, particularly triple-negative breast cancer, most of them do apply to BRCA mutated patients. Some of them, they apply only to those at this point in time. So I started with the guidelines for advanced breast cancer and the ABC5 guidelines. We stated that treatment of patients with triple-negative breast cancer, chemotherapeutic treatment, is similar to other non-BRCA mutated, BRCA or non-BRCA mutated are similar choices of chemotherapy. However, recently we have data on the effectiveness of platinum compounds, cisplatin or carboplatin, compared in the TNT trial with docetaxel. It is as effective and less toxic. So that is an option for the treatment. Also now we have the PARP inhibitors. We have 3 PARP inhibitors, olaparib, talazoparib, and veliparib. In the Olympiad trial, olaparib was tested compared to physician's choice of chemotherapy, capecitabine, eribulin, or vinorelbine. And it was noted that PARP inhibitors has a better effect and better tolerated. And the most common side effects is anemia. And this is something that we always watch the patient for. Patients may require a dose reduction. Then we had the IMBRCA trial, that tested talazoparib 1 milligram dose versus, again, choice of chemotherapy, capecitabine, vinorelbine, eribulin, or gemcitabine. Again, here in the IMBRCA trial, we have seen a benefit improvement with talazoparib, and also common side effects. Mostly it was anemia, and many patients do require interruption of the dose or reduction of the dose. Some patients require transfusion the first 3 months. That's when it happens. And then we have the veliparib used this time in combination, PARP inhibitor in combination with chemotherapy. We have a slight improvement, not significant, but only about 2 months improvement. So we are waiting for more data. So in the guidelines and at the ABC guidelines that I like to always mention, we have said that talazoparib, olaparib are a choice of treatment in those patients with PARP with BRCA mutation. Veliparib, we need to have more data on it. And the panel agreed that if a patient has estrogen receptor positive, there is no data to know which one is better sequence, PARP inhibitor followed by hormonal therapy with CDK4/6 inhibitor, or hormonal therapy with CDK4/6 inhibitor followed by PARP inhibitors. But the panel preferred starting with PARP with the CDK4/6 inhibitor and hormonal therapy first, and later on when patients recurred, PARP inhibitor, mostly because CDK4/6 inhibitor and hormonal therapy are much better tolerated. Also, we have data that PARP inhibitors can be used in patients with germline mutations other than BRCA. We have the data that was presented at ASCO 2020 using olaparib in patients with PALB2 mutation. We had an 82% response rate, while it was 50% response rate in BRCA mutations. So patients with PALB2 mutation can also benefit from using PARP inhibitors. The other aspect of treatment is immunotherapy. We have a lot of new exciting data about that. Triple-negative breast cancer tumors are immunogenic. We see that there is, high grade, lots of immunogenicity, high tumor mutation burden, also lymphocyte infiltration. So the immune system is important there. And we have a new immunotherapy drugs, the PD-L1. Also PD-L1 is highly expressed in triple-negative breast cancer. So we have the mostly now approved the talazoparib with nab-paclitaxel, as in the Impassion 130 trial, where the PD-L1 was tested using the Ventana 142 on the immune cells. This is very important. More than 1%, we have an improvement in progression-free survival and overall survival using nab-paclitaxel with atezolizumab. And then we had the keynote trial KN355 that used pembrolizumab with chemotherapy. But here we had a choice, not just nab-paclitaxel. Again, we have seen a significant improvement in the progression-free survival as well. So those two agents now are recommended. However, according to the testing that you do for PD-L1, you use the drug. If you're going to use atezolizumab, you do the SP142. You need more than 1% positive on the immune cell PD-L1. If you're going to use pembrolizumab, you have to use the CPS scoring system stain, and it is approved for patients who have more than 10% positivity on the tumor cells. To conclude, now we have options of using platinum compounds, using PARP inhibitors, and also using immunotherapy in patients with triple-negative breast cancer. This is why now we added in the evaluation of patients, we should counsel and recommend doing BRCA mutations in those patients with advanced breast cancers. Patients with ER positive, of course, get the PIK3CA mutation to see if they might benefit from alpelisib, and also patients should get PD-L1 testing as well, because they benefit from immunotherapy patients with metastatic triple-negative breast cancer. And with that, I thank you for your attention.